Hello, good morning. Thank you. No problem. Thanks. Hello. Good morning, everybody. I'm Dr. Narayan Swami, Department of ENT, Siddhartha Medical College. Okay, let me give you a brief overview about how do you evaluate, what are the investigations that you do whenever a patient comes to you with hoarseness of voice. To begin with, human voice is so complex that it not only conveys meaning, but it is also capable of conveying subtle emotions. When we are talking to somebody, we are not only talking to them, we are not only conveying our message through words, but we are also conveying our emotions. Okay, so hence voice is really the thing which makes us apart from all the animals. It's the most important physiological aspect that effectively starts to function immediately after birth. The first cry is the first voice of human beings. Before we go ahead, I would like to present to you a video about different voices. I request you people to not share these videos, maybe some copyright issues might come up. How our vocal cords behave, our vocal cords function. We are hereby passing a flexible nasopharyngoscope connected to the stroboscope. Okay, passing through the nose through 4 different pupils, going inside the nose, flexible nasopharyngoscope all on the floor, between the septum and the turbinate, inferior turbinate, going into the nasopharynx. From there, yes, we went into the oropharynx. Thereby, we are seeing the larynx. Can you see the beautiful picture of larynx? Of course, all of you will not be able to see. These are facilities which are available only in specialty clinics. But how I just wanted to bring about how beautiful vocal cords are and how beautifully they respond, how beautifully they behave in each of our voices. Please listen. See the subtle abductions happening. See the movement of the vocal cords. See not only the vocal cords but also AA folds and arytenoids. The movement of the epiglottis. In addition, accessory supporting structures, muscles, mucosal folds around the larynx. Okay, let's come back to our this one. What is hoarseness? per se, but the definition of hoarseness is, it is defined as any change in the quality of human voice. In lay terms, anybody can recognize what's a hoarse voice. But however, this term implies it can be breathiness, excessive air escape, roughness, the smoothness of the voice is gone, voice breaks or unnatural pitch changes. Voice breaks is interrupted, involuntary interruption in the speech. Unnatural pitch changes, patient will not be changing, but it itself changes as a patient keeps speaking. Together, we call all this under a term called as dysphonia. Layman's term is what on the hoarseness, we call it as dysphonia. To quote Shavlier Jackson, father of laryngoscopes, father of laryngeal surgery as such, hoarseness is a symptom of utmost significance. Hoarseness is a symptom of utmost significance and calls for a separate consideration as a subject because of the frequency of its occurrence as a distant signal of malignancy and other conditions. Such a beautiful coordination of words. With this just one sentence, he covers the whole of larynx. Wow. To broadly divide the cause of hoarseness of voice, they can be divided as a cause of hoarseness can be because of inflammation resulting from acute injuries like laryngotracheal traumas. Acute because hoarseness can be because of mucosal disorders of vocal folds. Like it could be as simple as inflammation associated with acute laryngitis, chronic laryngitis, sulcus vocalis, Rinke's edema. It could be because of benign tumors of vocal folds, something like vocal nodules, vocal cord polyps, vocal cord hemangiomas, or it could be malignant tumors right from stage 1, T1 to T4. Or it could be presence of laryngeal foreign bodies which itself can cause hoarseness, or neurogenic causes affecting the larynx. Like it could be flying paralysis, it could be recurrent laryngeal paralysis or superior laryngeal paralysis. All of these causes hoarseness of voice. So first investigation or the first examination that you do for evaluation of hoarseness is indirect laryngoscopy. All you people have been taught about this. Just to recap, we ask the patient, explain the procedure to the patient, pull the tongue out, hold it firmly using an indirect laryngoscope, mirror the headlight focused, gently pass the mirror before hitting the posterior pharyngeal wall till to visualize the structures. The structures seen are base of the tongue, epiglottis, lingual surface of epiglottis, laryngeal surface of epiglottis, arytenoids, AE folds, piriform fossa, vocal cords, true vocal cords, false vocal cords, then look for the movement of the vocal cords. This is how vocal cords will be whenever there is full adduction, then in abduction. So there is one more investigation that we do apart from for a detailed analysis. Other one is flexible nasopharyngoscope, which you people saw in the previous slide. Now stroboscopy. What is stroboscopy? Stroboscopy is an advanced instrument for further evaluation of hoarseness. It includes so many parameters to name a few. It takes into consideration the mucosal waves, mucosal folds, waves which happens, the movement, subtle changes in the movements of the vocal cords can be made out. Any early tumors to late tumors, all these things can be seen, documented with the video stroboscope. So here, instrument is passed. Similarly, can you see the movement of the vocal folds? How is this basic mechanism? I'll come to it shortly. So you can see the movement of the vocal folds, you can see the movement of the vocal cords, you can see how closely from lower part of the vocal cords to upper part, how the smooth movement happens from vertically as well as horizontal movement. Okay, so one more patient here. What is the basic principle of stroboscopy? Multiple flashes of light or multiple flashes of light continuously put up on the vocal folds, and all these things are reconstructed to give us an image. That's the basic principle of stroboscopy. I'll come to details of this later on. One more tool that we have for evaluation of portions of voice is doctor speech. It's a software which uses stroboscope as well as other parameters like electroglottography, wherein electrodes are placed on either side of the vocal folds and movement of this is documented. Electroglottography is similar to that of ECG for your heart. Similarly, it is EGG for your speech. This is a software. Doctor speech is a software. It also takes into consideration fundamental frequency. All of us will have some fundamental frequency. Only we can speak 30 decibels, 30 hertz above the fundamental frequency or 30 decibels below the fundamental frequency. So anything beyond that or anything below that extremes, we are harming our vocal folds. It also takes into consideration pulmonary function test. Together, this constitutes a software called as doctor speech. Now, before I go ahead, to give a few images which can cause hoarseness of voice, how it looks on an indirect on your direct laryngoscope with a rigid laryngoscope or flexible laryngoscope, documented pictures. In laryngitis, you can see that vocal folds are congested, and you see the margins of the vocal folds. So here, congested vocal folds, causes of laryngitis can be anything, right from infection to laryngopharyngeal reflex to sometimes maligns. Okay, one more picture. Hot topic, TB laryngitis. Though we are not seeing classical pictures like this. However, sometimes these are the documented images. Very rarely we do find isolated cases of TB laryngitis or TB laryngitis as part of generalized extrapulmonary pulmonary tuberculosis. Okay, these are your findings. As you people can see, there is the first and foremost finding is swollen epiglottis. It's partly seen. Swollen or turban shaped epiglottis, moth-eaten appearance or rat-eaten appearance of your nibbled appearance of your vocal folds, interretinoid granulations, multiple pale granulations. Okay, pale granulations in the interretinoid area. Vocal folds, you can see multiple small lesions. Edematous vocal fold, that's your TB laryngitis. Vocal cord polyp. Can you see a vocal cord polyp at the junction of anterior 1/3 and posterior 2/3 of the left side of vocal fold? This is the vocal cord polyp. Just a small video about related to vocal cord polyp. Give me a minute. Yes. Here's your vocal cord polyp, real live image through a stroboscope. Beautiful movement of the vocal folds with a polyp. Okay, small technical error coming by. So we taught the way some pictures related to TB laryngitis, vocal cord polyp, then comes a vocal nodule, vocal cord palsy, movement of the vocal cord, restricted movement of one side of the vocal cord. Through a stroboscope. Okay, this is how the voice of the patient looks. Listen to the voice. Okay, can you see the left side of the vocal cord of the patient is having restricted movement. There is bowing of the vocal cord, there is that's your vocal cord palsy. How will the laryngeal cancer look like? Okay, here is your stroboscopic picture wherein you can see a growth in the left side vocal cord, anterior 1/3 extending up in the anterior commissure. One more malignancy case. Okay, I think that's it. These were the images I just wanted to show you. Let's go for further more discussion. Give me a minute. Okay, to quote other pictures, this is Rinke's edema. Rinke's edema, as you can see, the almost bilaterally swollen bulbous vocal folds, TB larynx, vocal polyp, vocal nodules. To recap, hoarseness, it can be hoarseness, harshness, breathy voice, patchy voice. We do indirect laryngeal, we do a detailed oral cavity examination, oropharyngeal examination followed by ideal, then comes flexible nasopharyngoscope, then rigid laryngoscope or direct laryngoscope, then comes your stroboscope. And this was the image that we discussed. How do we do laryngoscopy? Further investigations in laryngeal diseases is to do X-ray. X-ray forms one more basic investigation. X-ray of the lateral view, X-ray neck lateral view. Mainly to look at the soft tissues, to look at the cervical spine, to look in the prevertebral space. I'm sorry for the mistake, spelling error. Soft tissue shadows, sometimes malignancy per se can be seen. High definition digital X-rays do bring about, give us a broad overview about the extent of the disease, extent of the growth. Cervical spine, not only for your malignancies but also for your other causes related to hoarseness because of the cervical, other causes, something like cord spine, cervical caries can be seen on X-ray of the neck lateral view. Prevertebral space, any unusual broadening of the prevertebral space, think about retropharyngeal abscess. From there further think in terms of TB larynx. CT of the neck is a standard treatment. We nowadays almost use CT neck for even benign lesions to know the extent of the lesions. With high contrast, high resolution, post contrast CTs help us a lot in managing even benign cases. So any case, any benign laryngeal, benign or malignant lesion of the larynx, CT of the neck is the primary requisite. X-ray, all those things are, yes, if facilities are not available, just you want to know a broad overview, you can go for X-ray of the neck. But CT neck, usually with the contrast, is the gold standard for further evaluation, especially if it is malignant role, do not touch the neck without doing neck CT scan with contrast. Not only it gives us about the growth of the dimensions of the growth, but it also helps us in picking up nodes which you might have missed during your clinical examination. Thereby you can upstage or downstage the disease. Further detection will upstage or downstage the disease. For detailed evaluation prior to surgery, as I told previously. Ultrasound, if CT not available or as an adjunct to CT, you also do ultrasound neck to look for any neck swellings. Neck swelling something as simple as a thyroid swelling, which can cause hoarseness of voice. Okay, by virtue of mere pressure or involvement of the recurrent laryngeal nerve or invasion of the paraglottic space. So all these things can be detected on ultrasound. Definitely yes on CT scan. CT not available, definitely kindly go for ultrasound of the neck. Ultrasound also helps us in identifying the nodes, neck nodes, especially malignancy, larynx, hypopharynx, oropharynx, neck nodes, secondaries, to look for vascularity of the mass. Post contrast also it can be done, but real time image, vascular masses evaluation, plus thermal ultrasound can be supplemented later on with MRI program. For evaluation of benign tumors, ultrasound, very quick investigative tool. Okay, coming back to stroboscopy, you people saw the pictures of stroboscopy. Coming to the detailed basic principles about stroboscopy. It's an instrument to study the periodic motion by shining a bright light at such a fast frequent interval so that a rotating object appears stationary. Okay, this makes focal fold movements appear slower. Whatever image that you saw, it was not real time image, it's a virtual image. By picking up multiple images, it was reconstructed. This makes focal fold movements appear slower and hence it is amenable. It allows us for assessment of the movement of the vocal cords. Okay. Further investigation in laryngeal diseases, especially hoarseness, is laryngeal electromyogram, which helps us in assessing the muscle activity of the throat and vocal cords. Wherein small electrodes are placed on either side of the larynx to measure electrical activity of the vocal cord. This test takes almost 20 minutes. As a passing reference, I am telling us. One more further advanced investigative tool. This is not advanced. Next investigation is advanced. This is video fluoroscopy, swallow study, wherein X-ray is used to monitor the swallowing process as you eat and drink food that contains barium. Patient is asked to swallow barium. Multiple X-rays are taken, follow similar to that of a barium swallow, but the study is restricted to evaluation of the functional evaluation of the swallowing. Now almost obsolete because we use endoscopic swallow study. Okay, so wherein patient is asked to swallow under and it is directly observed using a flexible endoscope. So that is called as endoscopic swallow study. Further investigation, any neck masses following non-invasive investigations like your ultrasound neck, CT, MRI, go ahead and do a fine needle aspiration cytology. Not only from growth, if it is extending directly from the larynx, but also mainly from the nodes. Okay, so this is investigation of larynx in brief for undergraduates. I request not to share the videos. This is only for departmental, only for the institutional purpose. Hope so. I've covered all the investigations. Any doubts? Please feel free to contact me in the department. Thank you.